So now having understood the basics about retinoblastoma, next we'll spend a PPT with how to investigate retinoblastoma and how to stage retinoblastoma so that we can plan management. Because in neoplasm, the staging at which the patient is seen by the medical team matters. If it is in a early stage or if it is in a advanced stage matters in the way the treatment protocol is going to be custom made for that particular patient. So we previously have seen that usually these babies are brought by the mother with leukocoria. So when the leukocoria is there, then we will have to dilate the baby nicely, dilate the baby and sedate the baby and do an examination of the fundus and try to visualize the fundus so that we can see the tumorous mass or see the exudative detachment. We can also check the intraocular pressure. We can use a tonometer and check the intraocular pressure of the baby because we have understood that the retinoblastoma can present as glaucomatous stage where the intraocular pressure can be raised. So these two examinations are very important. And also to take in history to see the pedigree chart of the family and to see whether there is already existent retinoblastoma are all important. But still more important is to do a B scan of the baby. We have to do a B scan. B scan is a scan, an ultrasound scan of the eye, vitreous cavity and retina of the eye. You would have also heard about A scan in cataract, where we said A scan will be done for IOL power calculation. Don't confuse that with a B scan. B scan is mainly a scan of the vitreous cavity and retina. So if there is a retinal tumor, then that tumor is going to show. Can you see a retinal tumor is showing? This is the retina. This is the retina. This is the retina, and in the retina a tumor is seen, and in the vitreous cavity also a tumor is seen. You are seeing a tumor in the vitreous cavity also, and it is the echogenicity of the tumor is hyperechoic. Can you see? It is hyperechoic tumor. Similarly, we can take an X-ray or a CT scan. We can take an X-ray or a CT scan, and in an X-ray or a CT scan, we can nicely pick out the tumor. You can see a calcific tumor because these tumor masses, have lot of calcium in them. The cottage cheese appearance, which we discussed, you remember. So that calcium will be radio opaque. So it will nicely show. Can you see? On the retina, there is a mass, and inside the vitreous cavity, there is a seedling. Can you see? Very similar to what is being presented in this B scan image. So this kind of retinoblastoma is bilateral retinoblastoma. So we usually presume this to be a familial variety of retinoblastoma. Okay. The next important thing which we do in these babies is to do a we have to do a enucleation of the eye, and the tumor mass has to be biopsied, and the biopsy will be confirmatory. Because there are a lot of conditions which can mimic a retinoblastoma. The conditions which mimic a retinoblastoma are PHPV. PHPV can mimic uh, retinal toxocariasis. Retinal toxocariasis can mimic retinopathy of prematurity. Retinopathy of prematurity can mimic a retinal detachment. A simple retinal detachment can mimic a case of simple cataract. Case of simple cataract can mimic. So there can be a lot of conditions which can mimic. We can also have characteristic retinoblastoma like appearance in many conditions, and these conditions together are referred to as pseudogliomas. Okay, they are called pseudogliomas. These pseudogliomas are like glioma is real and pseudogliomas are mimicking conditions. These conditions try to mimic a retinoblastoma. So when there are so many conditions which are going to try to mimic a retinoblastoma, then we will have to finally have a tissue diagnosis. So the final tissue diagnosis will show Homer Wright rosette. there will be a Homer Wright rosette. Can you see? This is a Homer Wright rosette. This is a Homer Wright rosette. And there will be Flexner Wintersteiner rosette. Flexner Wintersteiner rosette. Flexner Wintersteiner rosette. And undifferentiated tumor cells. Lot of undifferentiated tumor cells. Can you see? Lot of undifferentiated tumor cells. You will have florets. You will have florets also. Florets. So florets. So Flexner Wintersteiner rosette, a Flexner Wintersteiner rosette, a Homer Wright rosette, a Homer Wright rosette, a floret, and undifferentiated tumor cells will be pathognomonic of retinoblastoma. Pathognomonic of retinoblastoma and differentiated from the other pseudogliomas. Okay. Now we have to stage retinoblastoma. There was an original classification called the Rees-Ellsworth classification. There was a Rees-Ellsworth classification which was previously used, but now it is no more considered to be very fine and accurate. So we now have the international classification of retinoblastoma. And in international classification, we have a group A child who is at very low risk, who has a solid tumor which is less than 4 disc diopters. One disc diopter is 1.5 millimeters. So 4 disc diopters, think of it. Okay. And multiple tumors which are all behind the equator and nothing more than 4 diopters. A solitary tumor itself which has grown beyond 4 diopters to 10 diopters becomes group B. Any lesion anterior to the equator or a tumor which is even beyond 10 disc diameters is called group C. And group D is where multiple tumors of 10 disc diameters in size, multiple tumors of 10 disc diameters in size is, and a lesion, one tumor extending beyond the ora serrata is also very dangerous, because it has, if it is crossing the ora serrata, it is touching the choroid and touching the vascularity of, so that way we have to think. Massive tumors with vitreous seeding and massive tumors almost occupying 1/2 of the retina. So less than 4 diopters is one stage, 4 to 10 diopters is another, beyond 10 diopters is yet another, beyond 10 diopter and extending to the ora is another, and that with the vitreous seedling is one. So this is how we classify retinoblastoma. So now we have understood what is retinoblastoma tissue diagnosis, what is the investigations like B-scan and X-ray and CT scan going to show us, what is the staging which we do for retinoblastoma, and subsequently in the next PPT, we will analyze what treatment options we have for each of these staging. Thank you.